Delighted that Dr. Verdoorn is here again to speak, and Brandon is going to talk about an update on delirium. So Brandon, welcome back.
All right, so the crowd's thinning out a little bit as the weather gets nicer outside. That's a good thing. I'm glad everybody's enjoying the nice weather here in Hawaii. So I apologize, I'm back. You have to put up with me for another 30 minutes here, and we're going to try to talk a little bit about delirium and particularly touch on some important evidence that's kind of come to light in the past year or so. So again, I have nothing in particular to disclose with regard to today's talk. So at the end of the talk today, I hope that you guys can describe the basic epidemiology, etiology, and detection of delirium, that you can summarize a bit about recent literature on antipsychotic use for delirium, and that you can manage delirium, including that at the end of life, using proven non-pharmacologic strategies. So let's start off with a couple of questions just on some delirium basics. So which of the following adjectives does not accurately describe delirium? Is it common, serious, temporary, under-recognized, or do all of the above accurately describe delirium? Okay, and so all of the above, and so this is good. So I hope to teach you guys a little point here. And so probably our idea that delirium is a temporary condition is actually evolving, and there's starting to be increasing evidence that it's really not. And so there's actually a number of studies now going out as far as a couple years after an episode of incident delirium showing that people's cognition has not fully recovered. So I oftentimes, as a geriatrician, particularly in somebody with already having some underlying cognitive impairment, think of an episode of delirium as sort of a downward step on that staircase of progressive cognitive impairment. So many times it's not entirely temporary. So what are kind of some of the basics we know about delirium? Well, it's common. Probably a third of hospitalized patients over the age of 70. In higher risk groups, post-cardiac surgery, ventilated ICU patients, end-of-life settings, it becomes nearly universal. It's serious, so delirium is associated with a number of adverse outcomes: higher mortality, higher 30-day readmissions, higher nursing home institutionalization, more long-term cognitive impairment. And we're not great at recognizing it, so probably only about a quarter of cases of delirium are kind of the classic agitated, hyperactive delirium, patients trying to pull out their lines, get out of bed.